on the discussion section for the oral melanoma section discussing the clinical trials ongoing in the PD-1 refractory setting, on that discussion, I laid the groundwork stating that the response rate of 30% is really the bar in the refractory setting based on data looking at combination ipi-nivo and combination anti-PD-1 LAG-3 in the refractory setting. There were 3 abstracts presented. All of them were phase 1-2 studies, really signal-seeking studies, but none of these studies really met that bar of a greater than 30% objective response rates. But these were kind of early studies. So these 3 different clinical trials looked at a number of different therapies, including the Keymaker umbrella study looking at anti-TIGIT, anti-CTLA-4, a multi-targeted TKI, and a vitamin A derivative. Another study evaluated SX682, which is a CXCR1/2 small molecule inhibitor. And the third abstract discussed brenetafusp, which is a PRAME CD3 bispecific. And so in reviewing these abstracts, there were certainly some exciting signals. In general, these were well-tolerated regimens. But the question was, are we really adding more by exploring triplet therapies versus adding toxicity? There will be further exploration of brenetafusp, a PRAME CD3 bispecific, in a frontline study in combination with anti-PD-1, and I think more to come on SX682. The umbrella study, because those molecules did not meet their pre-specified objective response rates, will not be moving forward. So in general, the takeaway was, how do we find the best treatment for these patients in the refractory setting? And it's really understanding the mechanism of action, designing thoughtful clinical trials where we're using the best preclinical data that we have to identify the patients most likely to respond, and then embedding biomarkers even in the early clinical trials so we can use that information to move forward.